Hello, and welcome to the Two View, the cutting edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma, and I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area, and an adjunct professor of PA studies.
Hi, Mike. My name is Martha Robertson. I'm a practicing ED nurse practitioner and professor in Northern California.
Hi, Martha. We hope everyone's having a great and safe summer so far. We are recording this podcast within weeks of the terrible flooding that has struck multiple areas of Texas. The damage looks to be of like truly biblical proportions. We all hear about flash flood warnings on our phone and we think, oh, there'll be some accumulation and an underpass I might drive through. But it's just amazing how this went down. Dozens of feet accumulated in mere hours. If you live anywhere in Texas, even though it is a big state, you probably know someone who is affected, even if you weren't directly. Our hearts here in Dallas are broken for you, and my family and I are praying for you and sending support.
Yeah, I second that. I'm really sorry if you're going through anything difficult right now, especially that. And I will be thinking of my family that lives in Texas as well. They're doing fine, but
Oh,
thanks for
good.
thanks for the shout out to them. That was very nice. Um, this month we're back. We had a really great podcast last month with
Mhm.
Dr. Tubbs talking about all things radiology and burning questions we had about all things radiology. So if you didn't get a chance to listen, I highly suggest it. I learned some stuff. It was really a lot of fun. And of course, we invite you to come to one of our courses where you can see Dr. Tubbs live and in person once we get that scheduled. But in the meantime, we can hook you up with the video audio recording, and certainly your burning questions will be answered.
Let's get
But
started on some burning questions for right now, right? This segment one is where Martha and I talk about something that caught our eye in 60 seconds or less. It is the wet read, and we are on the clock.
yeah, we certainly are. I'm making sure, you're making sure, we're all making sure. So, I timed it for this one. Since we are going to be still fun for the summer, Mike, I'm going to talk about burns for 60 seconds. The question always is, what do I put on a burn? Is it Silvadene? Is it bacitracin? Is it honey? Perhaps aloe vera? What is it, man? Well, according to one meta-analysis by Levin et al. And Curious 2022, they compared silver Solvadine SSD or Silvadene to aloe vera gel. There's a growing concern over side effects associated with SSD use, as well as cost issues. And they're trying to find alternatives basically for some supplemental use here. And aloe vera gel was one of them. The systematic review and meta analysis demonstrated the time to healing with the use of the AV gel shows earlier wound epithelialization and pain relief with no or fewer side effects and equally efficacious antibacterial properties when compared to SSD. With all that being said, increased consideration and emphasis should be placed on the use of AV gel for patients to aid in the healing of second and third degree burns. Let's do this.
Well, yeah, I want to copy you here. I saw an earlier study, a randomized control trial, actually, in the journal Burns. I'm a big fan of one word journal titles, by the way. Burns, heart circulation. Props. I like the short and sweet.
Yeah.
Anyways, this article was way back in 2017 entitled The Effects of Honey compared to sulfadiazine for the treatment of burns, a systematic review of randomized control trials. We are big fans of the Cochrane group, and they use the Cochrane risk of bias assessment tool in their analysis here. The primary endpoints considered were wound healing time and the number of infected wounds rendered sterile. 9 randomized controlled trials met the inclusion criteria based on moderate quality evidence, which is not bad. There was a statistically significant difference between the two groups, between honey and silver sulfadiazine, and the study favored honey in healing time. They had a mean healing time of 5.75 days. And, sorry, I think this is it healed 5.75 days sooner with honey than silver sulfadiazine. That's my understanding of the study. And the proportion of infected wounds rendered sterile was 2.5 times with honey over sulfur sulfadiazine with good confidence intervals. The available evidence suggests that if you believe at least this study running up and including things before 2017, suggests that honey promotes better wound healing than silver sulfadiazine for burns. That's a pretty sweet setup we've got here.
Yeah. And Mike, did you know that honey really doesn't go bad? Like it doesn't go bad. So you can use it for a really, really long time. And if for some reason you don't want to consume it and you're like, hey, this is something I want to put on my body, just move it from the pantry to the medicine cabinet. And it looks like Big Pharma loses again. So consider deeply the evidence that we are backing and use honey dressings or the aloe or AV gel. And that's hot.
Well, speaking of hot, it is always hot in Vegas in the summer.
Yeah, actually, I was just thinking about you saying that, and I'm like, oh gosh, do I have to be there soon? Because it is hot as hell. Yeah, so summer, after summer comes fall, right? So in the fall, we have a boot camp, a huge boot camp. And we have redesigned a lot of our talks. We have some new experts, some oldies lecturing, workshops. Oh, the workshop's so great. And pharmacology, ultrasound procedures. This is big time.
Yeah, that'll be November 3rd and 4th for those pre-course workshops. The main course runs November 5th through 8th. This is the original emergency medicine boot camp. It's going to be in Las Vegas, Nevada at Planet Hollywood. And I'm not sure if everyone's aware, Planet Hollywood, not literally another planet. It's just a nickname. You don't have to know Jeff Bezos or Elon Musk to get to Planet Hollywood. You just like fly on a regular plane or you drive. This is totally doable.
Actually, I mean, you've been in there, right? It literally looks like you're in another world.
But it's not, though. That's the thing. I
Sure.
don't know if everybody knows this. It's not an actual planet.
This is true. Well, so, they also might be wondering how do they register? Just go to ccme.org and check out the course link. And you can use our hot little link that we've provided for you, which is just this little bit.ly link that we're
Mm.
going to put in the show notes. Instead of me saying all the way out, just click on the show notes, okay? It's listed in there. It'll take you right there. And then we can't wait to see you. So come on, so many great things to do. I'm telling you, you're going to have a good time.
And like if November feels like a long way off, number one, it'll be here before you know it. But if you need access to a course right now, then you can access a course right now. You can pause the podcast and you can go to www.ccme.org. That's www.ccme.org. You can get so many things. You can get the EKG interpretation workshop that me and Fred Abrahamian run as part of the Advanced Emergency Medicine Bootcamp pre-course workshops. You can find out how to decrease your chances of being sued by watching the high-risk emergency medicine course or the very new Bounce Backs course with Mike Weinstock and Kevin Clower. There's also the Mastering Pediatric Emergency Medicines course, Mastering Pediatric Emergencies course, rather, that Martha, you play a big part of. So there's just so many things.
Yeah, I feel overwhelmed sometime, but anyway, moving on. I wanted to just let you know, also totally off the cusp here. I was working yesterday. We were talking about burns, but we were talking about mupirocin, specifically, Bactroban. And I got two call backs from the pharmacy saying, oh, no, you can't prescribe the cream because the cream is not covered by insurance. Two different insurance companies, two different types of pharmacies, probably formulations as well. What I found was that the majority of pharmacies, according to our pharmacists, at least in my area, cover the ointment and not the cream. More specifically, it is to be just prescribed 3 times a day. If it is prescribed either 2 times or 4 times a day, it may not be covered.
Oh my
So
God.
if you do by chance want to only do 2 times a day, which by the way, 3 times a day is probably best, but if you do, just tell the patient that directly, although that does kind of get you into the weeds, because it's written on the bottle, excuse me, the tube. But just a couple of things. When you're prescribing mupirocin or Bactroban cream, consider prescribing the ointment. Not that it might be any more effective. I can't say that it is, but it might be covered by insurance. So thoughts?
Or if it's a minor burn, you just get some bacitracin over the
Yes.
counter. Frankly, that's my go-to. Like, much as I love honey and other things, bacitracin is my go-to for my uncomplicated first-degree burn.
Yep.
Well,
Or
next it is Dry Scan, where we penetrate a little bit deeper into two other topics. Speaking of burning, let's talk about burning one down. That's right, we're talking about marijuana again. At this time, it's my turn to talk about marijuana. Usually it's Martha, so I'm really excited to get into this myself. Specifically, a small cross-sectional study published in May 2025 in JAMA Cardiology that authors called the Candide study. It stands for Cannabis. Does it damage endothelium? Clever, clever, clever. This cross sectional study of 55 participants, age matched healthy adults from 18 to 50 years living in, Martha, you'll be excited about this, San Francisco. They're living in the San Francisco Bay Area in California. These people did not either smoke tobacco nor did they vape anything. And they were also not frequently exposed to secondhand smoke. So that was kind of like your criteria for entering into this trial. They were recruited into 3 cohorts. 2 of them were chronic cannabis user groups. One was marijuana smokers, another one was THC-Edible users, and then there was a one non-user group. Even though it was a small study, it found that chronic cannabis smoking and THC ingestion, so the edibles as well, were both associated with endothelial dysfunction, dysfunction to the inner linings of blood vessels, similar to that observed in tobacco smokers, although apparently working through different mechanisms physiologically. The authors suggest that this is the first study to examine the effects of marijuana on the vascular system, which is cool, but the study endpoints were things like different physiological measurements of certain blood flow metrics, nitric oxide production. These are obviously not patient-oriented outcomes or POOs. We want to know if there's any sort of benefit that a patient feels beyond things that can be measured in a lab. So what, if anything, does the literature say about patient-oriented outcomes, things like disease, disability, and even death? Well, in June 2025, just around the corner recently, the BMJ affiliated journal Heart, there you go again, a one-word journal title, love it, published a systematic review and meta-analysis entitled Cardiovascular Risks Associated with the Use of Cannabis and Cannabinoids. The authors examined a total of 24 observational studies and calculated that the estimated risk ratio was for people who used cannabis and cannabinoids. Estimated risk ratio was 1.29 for acute coronary syndrome, 1.20 for stroke, and 2.10 for cardiovascular death. So all of these suggesting an increased risk. If your risk ratio is above 1, that suggests an increased risk of these things if you happen to use cannabis and or cannabinoids. None of the confidence intervals crossed 1. So this is considered pretty significant. Of course, garbage in, garbage out. I'd have to go look at the individual studies, but that's pretty interesting. And it suggests that, cannabis is not necessarily the healthy drug that in all ways that it has been purported to be.
no, nobody has been saying it's the best end all be all drug, and I completely have been on both sides here looking at the literature, both to help patients and or take it away from patients literally that it's causing harm to. Um, and it's funny, being somebody that doesn't use marijuana, hasn't used marijuana, like it's just not something that I ever did or had any want to do. I literally have no opinion, I feel like, about it personally. And so I think I don't even err on the side of like, don't do it because I'm curious about, some of the things that it could potentially be helpful for. But what I will say is that I have added in my discharge notes now something very important that I'd like to share
Hmm.
with you. And in my discharge note, I have a dot phrase. And we've talked about this before, and it says like, "Dear so and so, your diagnosis is bleh." And then I say a couple of things, and this is the medicine I'm giving you. And then I said, I give this following information to all patients, and I cover 3 things. I cover insomnia, exercise, and drug and alcohol use.
Huh.
So I worked with a sleep specialist recently because I have terrible sleep apnea and insomnia, and I'm just work night shift. Um, and it's been really difficult for me.
Hmm.
So when I worked with this sleep therapist who is a cognitive behavioral sleep therapist, she told me a couple things that I think are really important and literally have changed my life that, you would think, oh, she must be so smart because she's a healthcare provider and la la la. No, I wasn't doing any of the things that she suggested, like going to bed relatively the same time every night and getting up in the morning at the same time every morning and keeping that schedule, your wake sleep time, and like lots of other things that we can share on a different show. But I put that in there, a couple of those things. Then in the next portion, I put things about exercise, like if you have no reason not to exercise, like you have a heart condition or, your doctor told you not to, you should be exercising. Do these things. And here's some link to Healthy San Francisco where you can figure that out. And lastly, I write the following words about drugs and alcohol. Alcohol is poison. It is in your best interest to never drink alcohol again because if you look at the literature, there is truly no supporting documentation that says that alcohol is beneficial for your health, even red wine. Now, that's harsh, strong language, but that's what I'm telling people. Of course, if they have an alcohol use dependence and are at risk for having seizures if they abruptly stop, that's a totally different story. This is just generalized information we give patients. And what I say about marijuana, which I know you've been waiting for the last 3.5 minutes, is I say marijuana is still a drug, albeit legal. It is a drug and can affect not just your lungs, but your heart. And if you continue to smoke marijuana or smoke cigarettes, you will die. I literally say just that. I know your face. You're like, that seems kind of harsh. But what do you think? You think it's too harsh?
No, I mean, it's funny that you mention it like that. I've recently, and this is a little bit tangential, but in terms of it's on the topic of discharge instructions, for some of these like relative, like non-emergent, but important to follow up on things, like somebody had hematuria recently. Of course, elevated blood pressure. We've talked to death, no pun intended, on this podcast. Certain things were all put in the discharge instructions. Failure to follow up about this condition as directed could lead to disability or death, because I don't want anyone to ever wonder, hey, how important was that thing that Mike talked to me about? It's very important. Like
Yeah.
all these things are very important. And so I talk about in my documentation of the case that I talked to the person about the potential consequences of non-adherence to treatment plan. So that's in the documentation of the encounter. And then I put it in the discharge instructions so that if somebody is non-adherent, that is their right. That's their God-given right to decide about their care. However, I don't want to be unclear at all about what I thought that they should do and the reason why they should do it. So we have come separately to similar places here in terms of being very, it sounds like heavy-handed with some of these things, but I don't know if patients get it
They
unless we
don't. That's
talk
why
in
I
that
say it. That's
way.
why I say it. And when couples come in and they read that, I go through it with them and they look at their partner and they say, it says right here. And they're like, really? And I'm like, yeah, if you want more evidence or research, I can tell you how to get that. And the thing about smoking, having been a smoker in my life, it was a horrible thing. And someone said to me once, um, Martha, no one's ever died from stopping smoking.
Hmm.
Okay. And if you continue to smoke, you will die from a smoking related illness. Full stop. Like it could be when I'm 95, it could be when I'm 55, but if I continue to smoke, then that was how I was going to die. So I think it's important that people realize that smoking just doesn't cause lung cancer. Smoking marijuana doesn't just cause lung problems, it causes heart problems, causes cardiovascular problems. It causes peripheral vascular disease. It causes all kinds of other issues, hyperemesis. Fine. You want to do some drugs once in a while, whatever. I'm not saying like that I'm judging you for that. I'm just telling you there's going to be a consequence. That's all.
Speaking about hyperemesis and marijuana, I do have kind of my take on how to address those patients who are very resistant to the fact that the marijuana could be causing their dozens of trips to the ER and
Mhm.
multiple non-diagnostic CT scans. So if you're interested in listening to that, you can go to our YouTube site. Go to YouTube and then you search for Center for Medical Education and look for a talk that I gave on upper abdominal disorders. I go over antiemetics to include cannabis hyperemesis. And I'll be honest, like when I'm in the, you know, swerve from what we're just talking about here, when I talk to the patients in person, I tell them like, hey, marijuana probably does a lot of things we haven't yet discovered. It's probably a
Mm.
pretty good drug. Uh, you know, because I want them to be kind of on their heels a bit. I want them to be like, oh, what? This guy is on team green with me? Like, yeah, like I at least want to show that I'm not um judging their
Oh
behavior.
yeah. No, that's not it at
No,
all.
no, and
No.
I didn't think you're not doing that. You're not
No.
doing that. I didn't interpret that. But I just it's a tactic to achieve some sort of connection with patients. And it's hard to make these strong pronouncements about somebody's health without a connection first. And so this is just a way to make that connection. And so I welcome you. Enjoy my talk. It's the same talk I
Hmm.
give at the original emergency medicine boot camp in November. I just have updated it a little bit, changed a case, but you have the OG version of my talk there on the YouTube. Feel free. It is at YouTube again. Search for Center for Medical Education.
But just to tie this all back in, I'm still very interested in the topic. I'm not throwing the whole thing out, right? Like, so there's some things about CBD and THC. I've talked about it on the show many times where it could, be useful. But smoking it certainly has not really been shown to do much beneficial, especially for anxiety, depression. So, moving on to our next burning topic, and this one is about burning eye pain from syphilis. Like to lay it on pretty thick here for everybody. And as you know, if syphilis goes untreated, it can lead to severe multi organ dysfunction. Eye involvement can occur at any stage of the syphilis infection involved in any eye structure and is considered a form of neurosyphilis. The standard care and treatment per the CDC is 1.8 to 2.4 million units of intravenous aqueous penicillin G, which is a change from the previously recommended intramuscular injection.
Mhm.
Uveitis from syphilis can cause permanent vision loss if identification and treatment are delayed. And this means we, as emergency medicine and urgent care NPs and PAs, have to be looking out for this.
Oh, looking out for it. I get it. It's an eye joke. Very good.
Yeah. Yeah. So, an article in the American Journal of Ophthalmology coming out in September 2025 examines the rise of syphilitic uveitis in the United States from 2013 to 2024. A database of medical encounters here, what they looked at, the study suggests new cases of uveitis from syphilis have doubled from 2013 to 2024, going from 0.27 cases per 100,000 patients in 2013 to zero point 0.8 cases per 100,000 patients in 2024. Consider uveitis in people with eye pain that involves photophobia, especially consensual photophobia. That's when you shine the light, in the good eye and it triggers the bad eye to feel the pain. And usually their eyes are very red, injected, and pain of uveitis does not go away with drops of tetracaine or proparacaine. That's because the problem is inside the eye,
Hmm.
not on the surface. So it's a good way, really. That drug just helps you figure out a lot of things. But diagnosing a patient with uveitis just tells the others, kind of what is going on. Um, and it doesn't really tell us why. These are often really big workups, including, sneaky diseases like TB and Lyme, herpes, simplex, zoster, and yes, we look for the syphilis. The accurate diagnosis of syphilis requires the combined use of the treponema test, like the EAI, CIAA, and the TPPA, and a non-treponema, like the RPR and VDRL test. And the safest thing to do is to order both. Okay. Just order them both. You can do it. Co-infection with STIs, other STIs have been reported in the literature. The infection with the highest percentage, like its biggest friend, co-player, partner, podcast winner together, is HIV. Okay. So add that to your workup as well, right? They're homies, they hang out, and that's their thing. Unfortunately, one follows the other. Here's the good news. Treatment within 10 days to 1 month of symptom onset has been associated with good outcomes. One study suggested 80% of eyes treated within 1 month achieve a visual acuity of 20/40 or better. Unfortunately, less than 20% of those treated after 3 months, hmm, uh, they achieve similar results and outcomes. But what I will tell you is that the longer you go, uh, the harder it is.
Yeah,
So,
so yeah, less than 20% of those treated after 3 months. So if there was a delay of care for 3 months, then only 2 out of 10 patients got up to 20/40 or better. So
yeah.
not great odds there for sure. This is one of those where I don't know about you, Martha, but now that I have again the means in county, I like to consult ophthalmology for these patients. Uh, Even though it's not like they're gonna like keep the patient, admit the patient. I like to consult with the idea that there's going to be close follow up required, and I
Yeah.
and I lead with that when I talk to the consultant. I say, hey, I don't think you have to see this patient today. You don't have to come down in the middle of the night or anything, but I just want to make you aware of this patient, how I want to make sure they get into clinic within a reasonable time. Can you give me what you like to work up these patients for? I'll get it ordered. I just want you to talk to your scheduler and get them on the schedule for the next few days so that if they have something like syphilis, like TB, like whatever, that they can have aggressive treatment for this, a vision stealing diagnosis. So
Hmm.
so don't be afraid to consult opto. It's consulting is not just for patients who you're trying to admit or for opto to visit personally. It's for patients who need close follow-up, and people with uveitis are definitely in that family of patients who need close follow-up.
Yep. I like it. I like it. Okay. As I mentioned earlier, Mike, um, I think that we need to continue on some of these burning topics, and I have a really good one for segment 3. So, are you ready for it?
Yeah, our oral contrast segment, I agree, is really good. We're going to get into all the nooks and crannies of a topic, and that topic is,
Uh, Herpes.
oh, goodness, yes.
Yeah. Okay. So we've talked about herpes before, NBD. We're going to, sparse it out here a little bit, but we're going to define a couple of things that get a little confusing here and there. And really, what better burning topic we could talk about, but the burning pain of HSV, herpes. So let's talk about HSV1, oral herpes first. So I want to answer some questions that are misunderstood so many times on the planet here. Is HSV1 and HSV2 the same? Can we pass oral herpes to the genitalia? And then I'm going to talk about the best tried and true treatments of HSV1. And let's remind and sadly normalize the audience about what the WHO has to say about HSV1. So, an estimated 3.8 billion people under the age of 50, 64% globally, have herpes simplex virus type 1 infection, the main cause of oral herpes. An estimated 520 million people aged 15 to 49, 13% worldwide, have herpes simplex virus type 2 infection, the main cause of genital herpes. And most HSV infections are asymptomatic and unrecognized, but symptoms of herpes include these painful blisters or ulcers that can reoccur over time again and again and again. So, HSV 1 and 2 are quite common infections and can cause visits to the ED or urgent care. And the main question we get asked a lot, like I said, is can oral herpes give me genital herpes? So, let's break this down with a few things. So, type 1 mostly spreads by oral contact and causes infections in or around the mouth, even in the inner portion of the nose as well. And we know those are cold sores, ulcers. And these sores and blisters are typically very painful. Blisters may break open, ooze, crust over, sometimes can get confused with other diagnoses. But once you've seen one, you're never going to miss one again. The patient will tell you that they feel like they were bit by something. They feel like maybe it was a bug bite or something, or maybe it was a zit that went bad. They might even have a fever or body aches or sore throat, headaches, swollen lymph nodes. They might have had a surgery recently, a stressful event. And repeat offenders know when they come and they come fast. So people will say, "Yeah, I know I have this. It's coming. I knew it was coming." And people have these recurrences. These are usually shorter and less severe than the first initial outbreak, but they can still be quite painful.
And this is spread by, said oral contact, or HSV1 is spread by oral contact, but that oral contact can be a lot of places. It can be to the fingers of dental hygienists. That's how people get herpetic whitlow. And oral contact can happen to someone's genitals. So this can be transferred to the genitals. Is that correct, Martha?
Yes. So I'm going to just kind of explain this. Oral herpes, HSV1, can be transmitted to the genital area through oral genital contact, such as oral sex. This means that someone has an active cold sore or even asymptomatic shedding of the virus, they have oral sex, and it can potentially pass this along HSV1 to their partner. And yes, if you share drinks, lip balms, utensils, you can transfer the virus. When HSV1 does go to the genitalia, it is less common to get outbreaks to the genitalia. So, yes, you can get HSV1 down there, but unless you truly have HSV2, the majority of your sores are going to be oral sores. In contrast, HSV2 rarely causes oral herpes. HSV1.
Both of them are really contagious, but the bottom line is HSV 1 and 2 can infect the oral and genital areas. Even though it's rare that HSV 2 goes north, it still can. They're both highly contagious. And so definitely people are at risk for transmitting these to either place.
Yeah. So just good rule of thumb, you just say it can go everywhere, period. End of story. You don't need to get into these, explanations of the one versus the two and a little less common or more common. Just skip it. Just say, be careful. Okay. Because neither virus is curable, but antiviral medication, like we know, acyclovir or valciclovir, can reduce the symptoms and transmission risk. And we'll talk about that in a moment. But even when sores aren't visible, there can be this asymptomatic shedding. So you can sometimes not really see it. But if you can see something and you say something, it's probably too late, right? So let's say that you notice you had a cold sore come out today and you're with your partner the night before, like it's very possible that they could have gotten some of that shedding. But I also want to look at a paper back in the New England Journal of Medicine all the way back in 1999 by Langerberg et al. And it was a prospective study of new infections with herpes simplex virus type 1 and 2. This is a large scale study following almost 3,000 individuals to compare the acquisition rates and clinical presentations of HSV1 and HSV2. It found that while HSV2 infections were more prevalent, HSV1 was increasingly responsible for genital infections, particularly among younger individuals. The study also highlighted that HSV2 infections were more likely to be asymptomatic, especially in men. So, looking at this even years ago, there is cross moving of all the HSVs like all over the place. So, again, take home, we already told you they can go anywhere and don't share stuff, period.
So now that we know what goes where, let's talk about treatment. What is the best treatment? How much? How long? Can we prevent these infections or flares with medications? And what is probably most important for a lot of our patients, how long do I have to not have sex
Right.
before I can, avoid catching this or avoid passing it on? That's a big question for a lot of patients.
Yeah. So now that I have the herpes infection, do I need to take drugs every day for the rest of my life? Yeah. The short answer is yes, you can. And it decreases the risk by almost 50% of getting a sore. Coin costs, coin toss.
There you go.
Let's look at a meta analysis to assess the efficacy of oral antiviral treatment to prevent genital herpes outbreaks in the Journal of American Dermatology in 2007 by Lebrun Vignes et al. This meta analysis reviewed 14 randomized clinical control trials involving 6,000 patients or so. It found that prophylactic oral antiviral treatments significantly reduced the risk of genital herpes reoccurrences by approximately 47% compared to the placebo. Effective regimens included acyclovir, that's 400 milligrams twice a day, valciclovir, 250 milligrams twice a day, or 500 milligrams once a day, and famciclovir, 250 milligrams twice a day. So if someone wants to take a prophylaxis, there's great evidence to suggest that it's going to, cut that change, cut that, them having that sore out in about half the time. I mean, I think it's a great idea. I know people that do this, and I would have no problems giving patients, I don't know, like a refill or two. Like if they're traveling or like somebody died or why not? It's antivirals are relatively safe meds and, everybody gets them.
What's neat about the acyclovir, you mentioned that was just twice a day. Like usually acyclovir is such a colossal pain to prescribe to patients. Like for the treatment of a flare, it's 5 times a day, right? But if you're using it as prophylaxis, you can really stretch that out farther. You're just only giving it twice a day. That's way more manageable for a patient. There's an option for valacyclovir once a day for prophylaxis prevention. So that's really cool that prevention is a lot easier in a lot of ways than dealing with it when it kind of flares up.
Yeah, my tried and true for patients is 500 of Valtrex. Like just take 500 of Valtrex once a day. If you want, that will decrease your risk by 50%. That's a big percentage in my mind. So do it.
Yeah. And the cost, those of you that have been around the way a bit and been practicing medicine for a while, you grew up in the day where it was like valacyclovir is so expensive, but now it's virtually the same cost as acyclovir. So there's no cost burden anymore. Roll with the valacyclovir. It's covered by most insurances. It's relatively inexpensive. Once a day is a very easy lift for many people. Okay.
Yeah, like if I want to be incognito and like I'm trying to discharge someone home from the waiting room, I'll be like the nurse will be like, "What do they need?" I go, "They need one big pill, one big blue pill in their paperwork, which is the Valtrex. It's a huge
Nice.
pill, giant."
I bet. Yeah.
Yeah.
Well, how about this? That's covering patients who have the disease and taking prophylaxis. Should partners take post-exposure prophylaxis if they're exposed to somebody who has herpes? So this is thinking of a partner who does not, as far as they know, have herpes. They were exposed to somebody who looks like they have herpes. Could we prophylax these people? Yes. So partners who are exposed to either herpes virus may consider prophylactic treatment in certain situations, especially if the infected partner has a lot of outbreaks or if the uninfected partner is at high risk for some reason. Those reasons would be things like immunocompromised or pregnant, things like that. Here's a quick breakdown. So, for the infected partner, okay, the most common strategy, a very common strategy, again, valacyclovir once a day. That is already dropping trend, not just infection like flare risk. So it's treating the flares, preventing the flares, like Martha said, by about 50%, reducing them by 50%. Not only is it reducing the infected individuals' flare occurrences, it's also reducing transmission risk by about 50%. So do it for yourself and the one you love, right? So that's pretty good. That's for the infected partner. How about the uninfected partner? Now, this is where we're getting a little off label, but it's something you could consider if, again, there was a known direct exposure, people saw the lesions. A short course of acyclovir or valacyclovir can be prescribed to reduce risk, especially if the partner had mucosal contact. So mucosal contact is the mouth, is the genitals. That's a little, again, more anecdotal. There aren't as strong guidelines there. What about the CDC and the WHO? What do they say? The CDC does not currently recommend it for the uninfected partner. Instead, they emphasize the infected partner be suppressed.
You okay there, Mike? I know you kind of had a little voice drop. Good. Take a little sip of water. This is a heavy topic with a lot of information. So, one of the things I also wanted to point out is that pregnancy is, if a pregnant woman is exposed for the first time, especially in the third trimester, antiviral prophylaxis for the uninfected mother may be recommended to reduce the risk of neonatal herpes. This is a high risk scenario and should involve OB/GYN consultation. Um, and then, Mike, this other question we had, the big burning question.
Yeah, it's how long do I need to avoid the infected partner so I don't get this? The idea is you want to wait until all the sores are completely healed. It takes about a week or two. It's a long time for some people. So but it's good information to tell the uninfected. Wait a week or two.
Yep. And then I want to talk about some uh, non-pharmacological stuff and also some topicals, but two important things that you will only hear on this podcast. I have not heard it anywhere else. Uh, well, actually, that's not true. Maybe it's somewhere else. But I see an esthetician. I get my Botox. I do the thing. I like it. Don't be a hater. Um, And I went to talk to her, and I said, "I had a patient the other day that came in, and they asked me to refill their Valtrex because they were having a procedure." And she goes, "Well, what procedure were they having?" I said, "Well, they were getting lip fill." Clearly I don't have lip fill. I wish I did, but I'm kind of thinking about it. But this patient needed to get a lip fill. And I said, "Do you need a prophylaxiball?" Because I had talked to the dermatologist. Anyway, this patient ended up going to urgent care, and I didn't end up seeing them and giving them a prescription, but they had asked for it. And yes, indeed, if you are getting Botox, lip fill, or anything around your mouth or nose area for a procedure, you are to do 2 weeks of prophylactic therapy if you're not already doing that, if you have HSV1,
Huh.
which I thought was
Okay.
really interesting. Um,
Yeah.
and on top of that, they're looking more and more into home testing for all kinds of STIs. Uh, and HSV is something that people want to test for at home. It's not very easy to do per se, but if you have an active sore, you certainly can swab it and send it. There are companies that do that. But I'll tell you a funny little story. It's not funny at all, but I knew somebody. Now I feel like we're one of those chat podcasts. I knew somebody. They were married for a long time. Okay. They got married when they were super young. They ended up getting a divorce. Now, one of the people in the couple had HSV too. They were very careful. They took prophylactic. We're talking decades of being married. They got a divorce. Not the other partner that didn't have HSV never got it. They
Huh.
decided to use an app, a dating app. Okay, I'm not going to say which one. The person that didn't have the HSV too after they got the divorce, who hadn't gotten HSV too, all these sexual encounters with their partner that had it. Okay, they went on one date, had one of those little fun nights. Herpes. Just letting you know.
Just any you roll the dice, eventually you come up snake eyes, I
No, but
guess.
I mean, doesn't that suck? I mean, you go all that time with somebody has herpes, and then bam.
I think this is a good time to point out that all the board questions, they are very ageist because if anybody on the boards has an STD, they're always under the age of 30. And I think that really it's funny
Yeah.
kind of, but it's like it also it skews us when we're out in the real world and you have people like you're just describing they are getting back into the dating scene in
Hmm.
their, sixth decade of life or whatever, and they're coming down for the first time with an STI ever. And so that's just unusual for us to encounter. We just need to be ready.
I think we're missing
And
it.
I mean, I would say myself, I've been kind of taken aback as far as oh my gosh, I have to explain an STD to somebody who basically could be my father or my at least an
Yeah.
older uncle, I've got to break this down for them. And it's kind of and for whatever reason I feel like patients of this age, they take the news a lot harder. I think
Yeah.
you're saying I went all this time and now, oh my gosh, I dipped my toe back into the pool and it's infected,
Watch where
you
you're dipping
know
your toes. All right. Jeez.
yeah. Toe HSV is even worse. I'm kidding. We're not even talking about that. But let's get back to these topical antivirals because there are a couple of them out there. So in terms of the topicals, rather, things you apply to the areas. Okay, so one is called acyclovir cream. It comes in a cream form. There's also pencyclovir, trade name Denavir, and then you may have heard of docosanol, trade name Abreva. Now,
Hmm.
Abreva is over the counter for cold sores and works on HSV1 in particular, and it may shorten symptoms by about a day if applied early. So that's not a huge help, but the nice thing is it's over the counter, and so somebody doesn't have to come in for that. Okay. Your antivirals are a little actually, it depends on which one, right? So your pencyclovir, that actually is FDA approved. So if you're doing something and you really need the FDA approved treatment, this is FDA approved for HSV1. It slightly reduces the duration about by a half a day or a day. You got to apply it every 2 hours. I don't do anything every 2 hours, so that's hard in terms of compliance. And then going back to acyclovir, I think the key thing for all of these is that you have to use them early.
Yeah.
Okay. And like with acyclovir, we're talking about within an hour of symptom onset. And so maybe this can be a part of your education process if you have the time to go through this with somebody who has HSV1. If they're asking you, like, I get this all the time, like, I hate having to come in here. Can I do anything for this to not be so bad? Well, number one, you can get a PCP who can prescribe you oral antivirals. And I'm not being like flip. It's like that's really, this is a disease you'll have to manage for the rest
Yeah.
of your life. So just like eczema, just like asthma, you need to get a primary care practitioner. I am, again, blessed to work in a system that has easy access and financial assistance to get folks into said PCPs. So that's key, is figuring out where people can go for primary care for recurrence of treatments. That'll get them on some sort of prophylaxis. And then second, you can advise them, hey, there are prescription and OTC treatments, but early is best here.
Yeah. And Mike, the key with once you get these, and I know people that get them, and I can tell if someone's really stressed out because their cold sore is worse than it usually is. And like those people tell me, like, I knew it was coming on, like I felt it. And they know that within that first 30 seconds of feeling that feeling, that they have to take their medication or apply something. But I have one friend that uses all of these homeopathic stuff. And
Mm.
honestly, it, I feel like it makes her cold sores worse. But I did look at the literature, which is part of what inspired this whole segment because I really was trying to help her out a bit. And there was no strong scientific evidence that homeopathic treatments effectively treat cold sores. While some people report symptom relief, right? So they might feel a little better, might take away some of the burning. Doesn't really stop the sore from doing its thing. Kind of just progresses and becomes an ulcer and splits open and oozes. Um, but the virus, it can't be cured. It can only be managed, and homeopathic really relies on the kind of these ultra diluted substances, or like cause more burning or irritation. But if you look at Cochrane reviews, they all conclude that there's no convincing evidence that homeo stuff is effective for herpes. But I will say, like, there's this great little chart in one of these papers that was like the remedy and then claimed effect, all in quotes, like, and evidence, which I thought was great because lysine is really popular. And the claimed effect is that it may reduce outbreak frequency. Really weak evidence, but it's safe. So people are like, whatever, I'm just going to take lysine until I can't take no more lysine. Like, I don't care. Like, it's generally safe. Whatever, maybe it'll work. Lemon balm. Yeah, antiviral properties, reduces healing time, mild benefit in some small studies. Eh, you know. Tea tree oil, which, by the way, I would not be putting tea tree oil on anything.
Mm-mm.
It is so drying and caustic, like when it's in that pure form. Either you dilute it and you're using it as an antiseptic wash of some sort, but I mean, this is just such an irritant. Like I had a patient come in who had a tattoo recently. Tattoo was getting irritated and infected. They kept putting tea tree oil on it and it
Mm-hmm.
got worse. And I'm like, well, duh.
Shocker.
Um, how about aloe vera gel? We were just talking about this at the beginning of the show. Yeah, actually, that can reduce some inflammation and have mild symptom relief. That's the only one that I thought was great. If you have an aloe plant in the backyard, go rip one off and rub one on there. See what happens. And then lastly, zinc oxide cream may speed up the healing. And there's some support for zinc oxide in topical use.
Rip one off and rub one on. That should be on a t-shirt, I think, for our
Yeah,
podcast. But
yeah.
one last thing, tansy. So tansy is a plant. The scientific name is Tanacetum vulgare. This is a plant native to Europe and Asia, big in the folk medicine world. Short story, tansy has been used as a face wash, and so it's like, oh, use it as a face wash. Maybe that will work for someone who has cold sores. In fact, in certain Irish folklore, bathing in tansy and salts might even cure joint pain. So maybe tansy is an option in certain cultures.
Yeah, so I brought this holy water today, Mike.
Hmm.
Just I'm thinking it's possible. I mean, I'm a Catholic, okay? And I will tell you, I always keep this in my bag at work because, believe it or not, it does have an effect on some of my very special patients. But I was thinking more about it when I was doing this research because the Christian group of religion really does believe in some of this stuff. I thought tansy was fascinating. You should read more about it. And honestly, they didn't have much back then. But despite its history, it's pretty toxic.
Mm.
So it's essentially, uh, it's not safe. It's not good. It doesn't show laboratory promise for fighting the herpes virus. And it's really not good to consume in any way. Maybe there was some stuff with the topical that could help. Maybe it was more of a drying thing because it was pretty toxic. But yeah, bottom line, rely on FDA approved antiviral medications for managing cold sores and genital outbreaks.
Nice.
Okay, it's time for our Tuvu trivia question. Last month, we asked in what year was the CAT scan invented and by whom? Hmm. Mike, well, the history of the X ray computed tomography goes back to at least 1970 with the mathematical theory of the radon transform. In October 1963, William H. Oldendorf received the U.S. patent for a radiant energy apparatus for investigating selected areas of internal objects obscured by dense material. The first commercially visible CT scanner was invented by Godfrey Hounsfield in 1972. It is often claimed that revenues from the sales of the Beatles records in the 1960s helped fund the development of the first CT.
Yeah, and Hounsfield units are used now as a measure of radio density for CT scans. They represent how much tissues absorb the X-ray technology used in the CT scan. So you'll see HUs, Hounsfield units, in CT literature sometimes. Well, our winner, David, you've been so aggressive in answering these questions. You get taken down at the finish line often, but you did it this month. I'm so proud of you, David Pecora. He may be like the most consistent answerer of our trivia question. And I'm thrilled, frankly, to give you a gift this month. So, David, you did it. Congratulations. All your hard work has paid off. Please, please. We've got your email, of course. So we'll just link you up with Meg and we'll get something nice to say thank
Yeah,
you for
and
all the years of listening to us. We really
I'm
appreciate it.
going to put some holy water on you too, David Pecora, when I see you.
Well, here is our new two-part trivia question. In the 1890s, an oil painting entitled Inheritance depicted a woman with a child that had signs of neonatal syphilis. Who painted this painting? And what painting is this artist best known for? Email us your two-part answer, any feedback or comments from this or any episode. Maybe you've tried Tansy. Want to let us know how it went. Write us at 2viewcast@gmail.com. That's the number 2viewcast@gmail.com. More information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
Yep, check out our courses. And we want to see you. That's it.
We'd love to see you. Thank you for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcast and Spotify. Search for Two View Emergency. That's the number 2 View Emergency, and it'll come right up. Ratings help us climb the charts. We have a staggering 4.9 rating on Spotify right now. I am frankly thrilled about this. So other clinicians get some Two View goodness. If you want to add that 2.9 rating, or sorry, 4.9 rating, please jump up. If you like YouTube and you want to see Martha's new backdrop, that's some sort of a scaffold or perhaps a music stand. I'm not sure what it is behind you. Who knows? You can let us know.
My plumeria plant that I just got in Hawaii.
That's really nice.
Yeah.
You can see my snazzy new polo. My wife got this for me for Father's Day. It actually was part of a big prank in my church. It actually made the news. It was on Not the Bee and some of the national shows where hundreds of us showed up with the same shirt for mass one day. So pretty cool. You can see that dope shirt I got from soccerreligious.com. Not a sponsor of Soccerreligious. But anyways, if you want to see all that stuff, go to YouTube, search for Center for Medical Education. You can watch the video version. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites you referred to. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Thank you, guys.
Show notes are by Dave Pett too, and by us. So
That's
thanks
fair.
again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today at the Two of You. Have a good day and a great shift. Going off air now.
Burn, baby, burn.
Do, 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 do. How do I turn you off? Really, how do I turn this off?
There's got to be a switch.
You have the same one. How do you do
I
it?
know it's in the bottom, no? On the side?
Well, give me 3 hours. I'll figure it out, you know?
Just unplug it.